The picture there was that of a pseudocyst, the second performer. How would you proceed to manage this patient with a pseudocyst?
Actually, a pseudocyst is just a localized collection of fluid within the epithelium, so it lacks the true epithelium of a cyst. So, for a pseudocyst, most of the times, if given proper rest and with conservative management, they resolve.
So it's important for us to differentiate
between a cyst
and a pseudocyst. Pseudocyst can be managed conservatively, while
a symptomatic cyst needs a surgical intervention.
Now, if there is a ruptured cyst, how would you like to proceed?
You mean by seeing in the
on the endoscope?
Endoscopy, if it is ruptured, then again it depends upon the patient and things, how the voice, because there is definitely a difference in the mass of the two vocal folds. Definitely there will be emotions. So we have to go with the surgical management.
So even if a cyst has ruptured, it is not going to settle on its own. So we need to do surgery. Would you consider it as an emergency technique?
I would feel that most of the cysts of the vocal cord are vocal emergencies because once ruptured, they adhere to the surrounding tissue. It's almost like a cholesteatoma which starts adhering to the ligament and the lamina propria around, and hence then causes scarring, and hence they should be removed as soon as possible, even if they are ruptured, even if they come with waxing and waning symptoms. Sometimes they rupture and they say, oh, my voice has become better. And if you can see the cyst or the remnant, I think you should go in and operate it.
How do you think we should proceed to manage this patient? Surgery?
Sure.
Yeah.
So this type of cases, usually I do micro with excisions. If it is over, they go for laser, catheter laser or something. Now, frequently we are using microdubular excision. So this remaining cyst to be removed by microdubular excision. So these are the better things supervision because it is not the vocal cord decided for, and awareness of recurrence also. These are the things you have to do.
Dr. Ranguri, this was an intro. How would you proceed to manage this? We did a microfracture to get the cyst out.
Yeah, there will be this posterior, there will be a fibrous band and anterior band, so we usually cut that, and Jackman sir has designed the scissor with the ball on one side so that it doesn't injure the cyst when we go through it. So we'll be able to remove it off the ligament and from the mucosa with the use of that scissor, because usually when we have a sharp tip, it's going to go and poke the scissor. So this ball doesn't do that. And if there is adherence to the ligament, then we take that off. Anterior and posterior, the string of pearl appears. So we cut the fibrous band and then we take it as a whole. If the cyst is ruptured, then we try to scoop off all the the remnant wall, what was there, we scoop it off and then we position the flap. Hyalase and steroid, we inject.
So this company makes this instrument, so I'm sure if we could know it, it will be useful for all of us here in the audience.
That is actually talking about that we have suggested a design and some local people are doing work.
So look out for this particular instrument because dissection of a cyst is difficult, and in case we rupture it, we should ensure that we remove it in toto with the cyst wall.
Yeah.
You would like to add on something?
Yeah, I would like to put this. I will do the dissection from the lateral part of the cyst as well after making the incision. That incision also should be not just close to the cyst but a little bit away. And in front of the cyst, which is very small, if you infiltrate too much, we cannot distinguish where to make the incision, like the demarcation between the cyst wall and the
So what Dr. Manju is saying is there is a role of subepithelial infiltration before we start dissecting the cyst, because this sort of separates it from the underlying
Yes,
tissue
hydrodissection.
which we
But-
need to preserve.
Yeah, not that too much.
Not
And
too much.
fibrotic bands is a pearl on string appearance, as Ravi has pointed out. So fibrotic band also we need to cut, but that too a little bit heavy, because cyst can extend to the fibrotic band as well in case the cystic fluid will come out where we cut. So and from then if you are separating it from the vocal ligament, then it is time to separate it from the epithelium on the medial surface and of the mucosa. And some part of the mucosa, if it is adherent to the vocal ligament, we can, vocal cord cyst, we can take the mucosa out along with the cyst. And vocal ligament, sometimes it is too much adherent. Fibrotic bands can be seen very well. So that has to be released with a blunt and sharp dissection.
And patience is the key. I guess all of you will agree with me. Now this is our next patient. This is a young teacher who had a vocal polyp excised about 6 weeks ago, and he came back with recurrence of hoarseness. I hope you can hear his voice. He had a very minimal hoarseness of voice,